All right, welcome back. Today we're jumping into part 2 on kidney stones, and this time we're talking all about surgery. This is going to be super high yield, so let's get right to it.
So here's our game plan. First, we'll tackle the biggest question of all. Do we even need to intervene? Then we'll break down our 3 main surgical tools: Wave Lithotripsy, Ureteroscopy, and PCNL. And to wrap it all up, we'll put everything together into a simple, practical algorithm you can use. Let's go!
Okay, first things first. Before we even think about which procedure to use, we have to ask the most fundamental question. Does this patient actually need surgery, or can we just, watch and wait?
So let's put you right in the hot seat. You've got a patient. They've got a 7mm stone. What are you going to do? Well, the answer really boils down to 2 key things: the size of that stone and just how stable your patient is.
It all starts with size, right? That's really the #1 factor. If a stone is tiny, I'm talking less than 5mm, there's a really good chance it'll pass all by itself. But if you're looking at a big one, something over 10mm, well, the odds of that passing on its own are pretty darn slim. That's when we know we have to step in. And then there's that in-between space from 5 to 10mm. This is kind of the gray area. Here we might give something called medical expulsive therapy, or MET, a shot. That's where we use meds like tamsulicin to help relax the ureter and hopefully help that stone on its way out.
I love this way of thinking about it because it makes it so simple. Just picture a traffic light. Anything under 5mm, that's a green light. We can probably just observe. But over 10mm, that's a hard red light. Stop. Intervention needed. That gray zone in the middle is your yellow light. Proceed with caution.
Okay, now there is one scenario that throws all those rules about size right out the window. This is the one thing you absolutely cannot afford to miss. We're talking about a true urologic emergency, an obstructed and infected kidney.
So, if your patient has an obstructing stone and signs of infection, we're talking fever, sepsis, maybe pyuria, which is just pus in the urine, you have got to act fast. Your #1 priority is not the stone. I'm going to repeat that. It is not about the stone. It is about decompressing that system immediately. We do that one of 2 ways: either a ureteral stent that goes up from the bladder, or a percutaneous nephrostomy tube that goes directly into the kidney through the back. And here's the critical part. Whatever you do not touch that stone. Don't try to break it up. Why? Because if you start messing with an infected stone, you can unleash a tidal wave of bacteria into the bloodstream and cause life-threatening sepsis. The stone can wait. The patient's life can't.
Okay, so assuming we don't have an emergency on our hands, let's start looking at our toolbox. First up is the least invasive option we have: Wave Lithotripsy, or SWL. So what exactly is SWL? It's actually pretty cool. It's pure physics. We generate these high-energy acoustic shock waves completely outside the body and then use pinpoint focusing to aim them right at the stone. It's like a sonic blast that shatters the stone into tiny pieces, basically like sand, that the patient can then just pass naturally.
So, who's the perfect candidate for this? Well, SWL really shines for stones that are inside the kidney itself and are less than 20mm. It can also work really well for stones that are high up in the ureter. In these situations, it's a fantastic, non-invasive first choice.
And this is a really big but. SWL isn't for everyone. There are some hard and fast no-goes. You absolutely can't use it in pregnancy or if someone has a bleeding disorder they can't control. It also starts to lose its punch in patients with obesity. If the shockwaves have to travel more than 10 centimeters through tissue to reach the stone, they just don't work as well. And maybe most importantly, some stones are just too tough. Really hard ones, like calcium oxalate monohydrate or cystine stones, will just laugh off the shockwaves. You can often spot these on a CT scan. If they have a Hounsfield unit reading over 900, SWL is probably not going to be your friend.
All right, so if SWL is out, what's next? Let's talk about option number 2, ureteroscopy, or URS. This time we're going inside to get a look.
Okay, so with URS, we're basically sending in a special agent. We take this incredibly small, flexible scope with a camera on the end, and we navigate it right up the body's natural highway, through the urethra, into the bladder, and all the way up the ureter until we are literally face-to-face with the stone. Then we thread a tiny laser fiber through the scope, usually a holmium laser, and just blast it. We can either dust it into superfine particles or break it into chunks we can grab with a tiny basket.
URS is really the workhorse of stone surgery. It's our go-to for almost any stone that's stuck in the ureter, especially if it's in the middle or lower part. It's definitely what we prefer for those bigger ureteral stones, over 10mm, and it's our rescue plan. If SWL doesn't work or if a patient can't have it because they're on blood thinners, for example, URS is the answer. All right, now it's time to bring out the big guns. This is our most invasive procedure, but for the biggest, baddest stones, it is by far the most effective. We're talking about Percutaneous Nephrolithotomy, or PCNL.
So PCNL is a totally different ballgame. Forget going up from below. With PCNL, we make a small incision in the patient's back and create a direct tunnel, a direct access port, right through the skin and straight into the kidney. It's like building our own private expressway to get right to the stone.
You only use PCNL for the really big jobs. This is the undisputed heavyweight champion for clearing out huge kidney stones, anything over 20 millimeters. And it's the absolute procedure of choice for those crazy-looking Staghorn stones, the ones that are so big they form a cast of the entire inside of the kidney.
So this really lays out the trade-off, doesn't it? The pro is huge. PCNL gives you the absolute best chance of getting a patient completely stone-free, especially with a massive stone, in just one operation. But the con is also significant. It's the most invasive option we have. It means a hospital stay, and it has a higher risk of complications, with bleeding being the one we worry about the most.
Okay, so we've met the players. We've got SWL, URS, and PCNL. Now let's put it all together and figure out how to choose the right tool for the right job.
This is your mental checklist, your algorithm. Here's how you should think it through every single time. Number 1, is this an emergency? Do I see signs of obstruction plus infection? If yes, stop. The answer is urgent decompression, period. If no, move to step 2. What's the size? Is this a huge stone over 20 millimeters or a Staghorn? If yes, the answer is PCNL. If it's smaller, we move to step 3. Where is it? If it's in the middle or lower part of the ureter, URS is your best bet. If it's in the kidney or high up in the ureter, you've got a choice between SWL and URS. The only little exception is for a stone in the lower pull of the kidney. Gravity works against us there, so it's tough for fragments to pass after SWL. So for those, URS or even PCNL are usually better.
Look, if you walk away with just one sentence from this entire explainer, I want it to be this one. Say it with me. Size and location dictate the plan. Infection dictates the priority. That's the whole thing in a nutshell.
Okay, let's recap the super high-yield points for your exams and for the wards. Little stones under 5 millimeters, they'll probably pass. Big ones over 10 millimeters, they'll probably need intervention. See infection and obstruction together? Decompress first, ask questions later. SWL, great non-invasive option for smaller kidney stones. URS, the go-to workhorse for stones in the ureter. And PCNL, that's for the biggest of the big. Got it?
So we've gone to all this trouble to get the stone out, we're done, right? Well, not quite, because getting the stone out is only half the battle. The real question is, how do we stop the next one from forming? And that is a whole other story.